Good afternoon. This is Dr. James Marion broadcasting live on tape via Zoom for our third Thursday at the Susan and Leonard Feinstein Inflammatory Bowel Disease Center Facebook Live broadcast. We have a very special guest today. This is Dr. Mansi Agrawal, who is our current present Levison Advanced IBD Fellow here at Mount Sinai. But there's something important to know about Mansi. Mansi actually was a COVID colleague as well of mine. We were on really one of the first teams treating patients on the COVID unit, where I can personally attest that Mansi served valiantly and quite effectively. I think we did a pretty good job there, Mansi. So after being an advanced IBD fellow, and then more recently a COVID expert on an inpatient unit, I'm very happy to announce that Mansi is going to be one of our newest faculty members after graduation tonight, Mansi, as an instructor of medicine here at the Icahn School of Medicine. So I'm really thrilled, Mansi. I can't tell you how proud I am of you and how happy I am at the next chapter. Mansi is very active in clinical trials, has a keen and astute mind, understands the literature really well, and I couldn't think of anybody better to join us to talk about IBD highlights from Digestive Diseases Week this year that you may have missed. And the reason you may have missed them is none of us were there. It didn't really happen except virtually. So I wanted to emphasize some of the more important topics that were discussed at our virtual DDW, because I think there's some important new knowledge here that may have been eclipsed by the pandemic. Mansi, welcome.
Thank you so much, Dr. Marion, and thank you for all the kind words. I learned from the best. I'm so excited to be here, and I'm thrilled to stay on.
Well, listen, I always thought you were the best choice for the fellowship, and you're just proving it right. I would warn our audience, keep an eye on Mansi. She's going to be producing great work. So, Mansi, what did we miss? Give me a sense of a couple of things that we should have been, or we would have been maybe better aware of, or more aware of, had we attended DDW in Chicago this year.
Sure. So I think there were some very interesting works that were submitted to DDW, which we attended virtually. So there are some very important takeaways. I think one of the most interesting things that I found was the excellent epidemiological studies that came out of DDW this year. As you know, epidemiological studies, especially when they're based out of very large cohorts, over tens or hundreds of thousands of persons, or they're population-based, they provide very robust databases to identify risk factors for IBD, something that we haven't, made very much headway into, and something that's critical to understanding why IBD happens and which populations are susceptible to it. So some of the great studies that came out looked into these specific factors. One study was from the Nurses' Health Study out of Boston, and they looked at food diaries and food questionnaires from over 200,000 persons, and this was over 20 to 30 years of follow-up. So the total person time follow-up in this study was over 5 million. And they sort of divided foods into different categories based on their inflammatory potential. And these inflammatory foods included refined sugar and refined grains, processed meats, soda, and so on. And interestingly, they found that persons who had a higher consumption of such foods were more likely, about 45% more likely to develop Crohn's disease, but not ulcerative colitis. So that sort of speaks to the relevance of early life risk factors and cumulative risk factors, especially in Crohn's disease risk. And I think that's very informative.
That is very interesting. I think that nurses study is a database that just keeps giving us useful information, and that's fascinating, and I'm glad you brought that up. any breakthroughs in terms of new medications or new drugs that we should keep an eye out for this year?
Yeah, so we didn't see any breakthrough new drugs yet. I mean, there's several in the pipeline, and I know they're going to be talked about in the upcoming meetings. But in DDW, we actually had a lot of interesting data on positioning of medications and how to use the drugs that we already have. So for instance, there was the SERENE study, which was led by Dr. Jean-Fred Colombel, who's the director of our IBD center. And this was a randomized control trial over multiple centers across the world. And what they did was they studied adalimumab or Humira, which is a very old drug. They studied it in ulcerative colitis. They had 3 arms. They had the regular dosing of Humira, which is every other week, then weekly dosing of Humira, which is sort of an accelerated dose. And then there was dosing based on drug levels, Humira drug levels in blood. What they found was that even though there wasn't a statistically significant difference between weekly and biweekly dosing, persons who got it based on levels had an escalation of dose from biweekly to weekly in majority of cases, and they were doing well. So this sort of speaks to the importance of serological drug levels and the impact of weekly dosing. And there were no safety signals. So meaning that weekly dosing is safe and effective, and it underlines the impact of measuring drug levels in our patients.
So really tailoring the dosing of a drug like Humira the same way we tailor it to, with virtually all of the biologics, except probably Stelara, is clearly important. So that sort of therapeutic drug monitoring, being nimble with the dosing, individualizing treatment clearly has some role and benefit, even with Humira treating UC. That's good. That's good.
Absolutely.
That's good to know.
Yeah.
And so one thing that happens with IBD is we are always aware here at the IBD Center, in fact, we have it built into our brick and mortar, the idea that ours is truly a multidisciplinary effort. This is not, we are not living in a silo here, as it were. So any data on multidisciplinary care in IBD at DDW this year?
Yeah, so this was one of my favorite things in DDW this year, because it just speaks to the importance of multidisciplinary care and how IBD impacts all aspects of our lives. So this was a study, again, out of Mount Sinai, led by Dr. Ryan Ungaro, who has started a very interesting program called the Comprehensive Care for Recently Diagnosed IBD, or COMPASS program, in which patients who are newly diagnosed with IBD meet with a gastroenterologist, a nutrition specialist, social worker, and a pharmacist. And a very personalized, individualized plan is made for each person. All of their questions are answered. They're provided with a lot of insights into their disease, and specifically what they need is, those needs are catered to. So in this study, Ryan and his colleagues looked at 120 patients, 60 of whom were enrolled in the COMPASS program, and the others were getting standard of care. And they found that in every aspect of care, meaning just control of disease and patient satisfaction and steroid use and so on, in every aspect, persons who were enrolled in the COMPASS program did better, which is really exciting.
Yeah, I know many of my patients have benefited from that trial, and of course we all learn immensely seeing how they're managing these patients from that point of view.
Yeah. As have mine.
Yeah. So any sort of other diagnostics or point of care studies that we should be aware of that I know is something that is sort of started creeping into our literature over the last few years? Anything we should know about?
Yes. So for that, it's the ultrasound, the point of care ultrasound, which is also quite exciting. And this has picked up in Europe, but in the United States, it's not as incorporated in our clinical practice as we would like for it to be. Although again, at Mount Sinai, I know Dr. Dubinsky is working on integrating it in our practice. So this is a very simple ultrasound. It can be done bedside. very easily accessible. It can be done while the patient is at the IBD center to see us. It's inexpensive, there is no radiation exposure, and you get the results in real time. Essentially, this ultrasound would measure the bowel wall thickness, which is a measure of how much inflammation there is. So there were multiple studies in DDW this time looking at the impact of this ultrasound. One of these studies demonstrated a very strong correlation of ultrasound with the Maria score, which is an MRI score, and also with endoscopy scores, which implies that we could use it as a surrogate to measure inflammation and sort of stage the severity of inflammation in our patients. Then there was another study to assess the changes in ultrasound with healing. So they did ultrasounds before and after giving patients infliximab and other biologics, and they found that ultrasound healing does correlate with other aspects and other measures of healing, which again is sort of speaks to its utility in our clinical practice.
Right. And actually seeing direct results and direct benefit with our therapies instead of sort of guessing and basing it on symptoms, always better.
Yeah.
So finally, I wanted to you mentioned another study about patient preferences and therapies, which, often plays a, pretty central role in, when we're teaming up with our patients and trying to come up with a treatment plan. They're really clearly important members of the team. Could you elucidate on that for me?
So there was this really interesting French study, a multi-center survey called ACCEPT-2, in which they obtained, they asked patients questions about their preferences in terms of their treatment frequency and route of treatment and so on, and to get a sense of what they would prefer and what's acceptable to them. Because I think that's a very important component of us taking care of our patients, something that we should always keep in the front of our minds. So let me ask you, what route and what medication frequency would be the most acceptable to you? Let's say if you were to choose between a pill every day or a subcutaneous injection every 8 weeks, which one would you rather do?
Oh, every 8 weeks.
Right.
Absolutely.
And that's exactly what this study showed. So, it seems a little bit counterintuitive because this is an injection as opposed to a pill. But the idea of having to do it every single day versus once every 8 weeks. So according to this study, doing injections infrequently was better than doing pills every day, which in turn was better than IV medications every 4 weeks or every 6 weeks. So meaning it just, again, highlights the importance of what patient preferences can be, and something that we should always ask our patients about and take into account when we position our medications.
Well, listen, and I want to thank you for demonstrating my rather continental, if not French, taste here. Just want to point that out. I'll let John Fred know that I survived that study.
He's going to be so happy.
Mansi, these are, I think, very important, bits of new knowledge. And again, every day here, we're trying to push back the borders of ignorance here at the IBD Center. It's nice doing it in IBD again instead of with COVID, which we still have a lot of work to do, obviously. But I want to thank you for joining me. And again, congratulations on your next chapter. I'm very excited for you. And I have a hunch we're going to be seeing you again on this Facebook Live broadcast.
Thank you, Dr. Marion. It was wonderful joining you.
So I'd like to thank you all for joining us. Please join us again next month for the third Thursday Facebook Live broadcast from the Susan and Leonard Feinstein IBD Center here at Mount Sinai Medical Center in New York City. Stay safe.